So good afternoon, everybody. It's our pleasure to do our second Saudi STEMI program session today. I think today we're going to present our work last year, and we'll show you an impressive data. It's my pleasure also to co-chair with Dr. Khalid Al Habeeb, who is the director of the Saudi STEMI program and president of Saudi Heart, as all people know. Dr. SHA-MC is interventional cardiology and head of cath lab in King Fahd Medical City. Without any delay, I would like to introduce Dr. Khalid Al Habeeb to give us his first presentation about the Saudi STEMI program. Dr. Khalid.
Bismillahirrahmanirrahim. Assalamu alaikum. Thank you, Dr. Fawaz. So the session today is to give you an overview of the program that we started more than 6 months ago. The Saudi STEMI program is pioneered by many people, some of which you can see here in the podium, and some are basically in the hospital practicing. So this is a teamwork of many people that started this with a passion to improve the patient's care. I'd like to also thank basically the Ministry of Health represented today in Dr. Abdurrahman Al-Gahtani, who's the current head of the Emergency Department Support Program, which is currently basically supporting this very program. So برنامج تطوير طرق علاج جلطات القلب الحادة بالمملكة العربية السعودية, Saudi STEMI program. My job is to go over the data of acute care syndrome and registries and studies that we have done in the last decade in Saudi Arabia and the Gulf region, and compare this with international figures and why we need such a program. And I'll finish as well and end by giving you some achievements of how the program is progressing. And Dr. Fawaz Mtairi basically will go over the initiation, the challenges, how did we start, what did we go through, and then Dr. SHA-MC will basically reflect on his experience so far as the head of the cath lab in King Fahd Medical City. He has his own feedback and points to mention about this program, and then we'll hear from you. So a real case, this is a Syrian man, 55-year-old, who's a heavy smoker. At 2 a.m. he had severe gastric pain radiating to the shoulder. And at 7 a.m., after 5 hours, he was brought by his son, not by an ambulance, to the chest hospital, had arrhythmia, DC shock, he had an anterior acervation myocardial infarction. At 9 a.m., he was at King Salman Hospital in shock, blood pressure 60/30, anterior STEMI, inotropes, because of a lack of a cath lab hospital accepting the patient because no beds and basically trying to communicate with here and there, no beds. The patient was given thrombolytic therapy. He was put on a HALA system, still no beds in the on-call hospitals that are the university and the medical city for the program. And at noontime, patient had a cardiac arrest, CPR, and 1 p.m. dead. You can pinpoint at least 7 to 10 mistakes in the management of this patient, starting from the chest pain onset and to the end of his demise. So I didn't start with a success story. I started with a death of a patient to understand that as we speak now, somebody is dying somewhere in this country that could have been saved. To go over some quick definitions, acute care syndrome is divided into STEMI and non-acervation ACS. STEMI, you have a totally blocked vessel, while non-STEMI is subtotal occlusion. And to make sure that we are talking the same wavelength, When you take the patient immediately to the cath lab, this is called primary PCI, and when you basically, or the other option, you give thrombolytic therapy. Still, streptokinase, unfortunately, is the most commonly used in a wealthy country like Saudi Arabia. And when you take the patient from after thrombolytic therapy to the cath lab within 6 to 24 hours, this is called pharmacoinvasive approach, or drip and ship. And this is, so it's important to understand this terminology for junior staff. There's something called pharmacoinvasive approach. And basically, if the artery got open within 90 minutes, you take him to the cath lab next day or within 24 hours. This is called elective PCI. And the other part of the pharmacoinvasive approach, rescue PCI, if the thrombolytic therapy did not work and you have to get him for rescue PCI. Another concept is pre-hospital thrombolytic therapy, which can be as good, if not better, than primary PCI if you do it in the first couple of hours of the patient presentation. Now, it's understandable and very well known in the guidelines that primary PCI is a recommended method of reperfusion. It's superior to thrombolytic therapy if it is done, and this is the buzzword, by experienced operators, the people who have a lot of experience and volumes, who have a lot of, that do this on very busy along the whole year. And you can see here, you have to do it in a timely fashion. So basically, you have to do it within 90 minutes or less from first medical contact to device time. And basically, you have to be very efficient from, in terms of transfer. You can accept up to 120 minutes for patients who got transferred from a non-cath lab to a cath lab hospital. So you allow up to 120 minutes if you transfer a patient, and if the patient presents to your own emergency, it is 90 minutes. Now, it's this class 1, if you compare only primary PCI to thrombolytic therapy. But if you actually compare this to thrombolytic therapy and getting the patient to the cath lab within 24-hour period, I will show you that they can actually be comparable. This is a picture that I always show in my presentations. I'm proud of. This is the group that started the first acute syndrome registry in this country, space registry, Saudi project for assessment of coronary events, that basically led to a plethora of publications in local and international journals that basically told us about what's happening in the country over the years. This is a publication in the Journal of the Saudi Heart, and you can get this online for free. And out of this registry came many publications regarding diabetes, regarding comparing gender, male versus female, age, and what's the relationship to ACS, and heart failure, renal failure in a patient with acute syndrome. We went on and we did a registry over the Gulf region, and we did what's called Gulf Race, Gulf Registry of Acute Coronary Events, and collaborating with other countries in the Gulf. And publications that went all the way to circulation. This is a publication about CAT and ACS, and comparing gender in the Gulf region, and the access to the cath lab. And this is in collaboration with Sanjeet Julie and Salim Youssef from McMaster. And to summarize 10 years of experience in this table, basically you have National Registry Myocardial Infarction, the Global Registry internationally, the Euro Heart Survey, the Indian Registry, CREATE, and the 3 registries that I just told you about, the Space Registry in Saudi Arabia, Gulf Race 1 and Gulf Race 2, which are basically ACS registries in the Gulf region. Gulf Race 2 basically had 1 month and 1 year follow-up as compared to Gulf Race only. And you can see the number of patients collected here, thousands of patients that were collected from the Gulf regions over the years. And you can see the first point that we learned, that patients in the Gulf region present at younger age, 5 to 10 years younger than the Western Hemisphere, compared to Canada and the States and Europe, Western Europe. And if you talk about STEMI, symptom onset to hospital arrival, this is a trend worldwide. People tend to now to come earlier to the hospital, 132 dropping to 96 minutes in the States, dropping in the global registry from 140 to 120. Very long in India, it's around 300 minutes. In our case here in Saudi Arabia and the Gulf region, it is basically 200 minutes and 300 minutes. So our patients present at much younger age, and they take longer time to come to the hospital. And another point to mention that particularly in the Gulf region, we have more expats, particularly in Kuwait, Qatar, and United Arab Emirates. They basically, you have it the other way around. 80% or so, because obviously of the nature of the population, are expats who present with ACS. Around 1/3 of ACS patients are expats in our country. And it can go higher with STEMI. It can go up to 40 to 50% sometimes, which has very important health implication, particularly knowing that basically non-Saudis have limited access to healthcare overall. And now, if you want to have some comparison, if you look at the SHA-MC registry in France, basically doing snapshot from all over France in 95, 2000, 2005, and 2010, you can see here the symptom onset in France is dropping from 240 minutes to 175 minutes, and primary PCI use is increasing from 12% to 61%. So we are basically here. We are France in 1995, and we are now in Saudi Arabia in 2016. This is just to give you some comparison. How about comparing primary? People always say primary PCI is better, but remember, there are many good data that suggest particularly this is very applicable to a country, large geographic country with a healthcare system of ours like Saudi Arabia, that when we push for primary PCI, there is a very good data to support pharmacoinvasive approach. So you drip and ship. You basically give thrombolytic therapy and transfer the patient to the cath lab. This is a publication by Paul Armstrong from Edmonton in the New England Journal of Medicine that's showing that STEMI presenting it at less than 3 hours from symptom onset, those who got a primary PCI are as good as those who got thrombolytic therapy and went to the cath lab within 24 hours. So this actually is a misnomer, and actually the title of the paper does not reflect the actual study. It is actually should be called primary PCI versus in pharmacoinvasive approach, because this arm is not just T and K. It is T and K and going to the cath lab within 24 hours. So if you take the patient for rescue PCI, if the artery did not get open, or for rescue, or you do an elective if the artery got open within 24 hours, you can be as good as primary PCI. Now, this is from a randomized trial. You might ask, well, does that apply to real-life practice? This is a recent publication in Circulation 2014, again from the SHA-MC registry, that comparing real-life registry about STEMI, comparing no